Perfect. So I think this is a good time to get started. Good morning, good afternoon, everyone. Thank you for joining us for the second webinar of the Humanitarian WASH Research Updates. I'm Yitka Hiscox. I'm the project manager for the USAID BHA project that's behind this webinar. Today, we'll be talking about the latest research on case area targeted interventions in cholera response. The webinar is captioned in French. So if you would like to turn on your French subtitles, just use the CC button on your Zoom window. We'll start with a 5-minute summary of the existing research, and then each of our speakers will present for approximately 10 minutes, and then we'll spend the rest of the time on Q&A. So please type your questions and comments into the Q&A window. If you see a question in the Q&A that someone else has asked, and it's the same question that you have the option to like it so that it gets priority in being answered. And now I'll hand off to Danielle, who is a professor at Tufts University, and she will start us off with brief introduction on existing CATI research.
Good morning, good afternoon, everyone, and thank you for being here. As I think we all know, cholera is currently surging in more than 30 countries. And the Global Task Force on Cholera Control has a roadmap to eliminate cholera as an end goal and control it in the interim. As part of these strategies, it is recommended to complete targeted responses in cholera hotspots, as opposed to blanket programming or mass campaigns like may have been done in the past. Today, we're going to be talking about the control piece of the control prevention elimination strategy. So case area targeted interventions are one piece of the control strategy, and they compose of two pieces. First, CATIs are a delivery mechanism. For example, a case comes to the health center, and that triggers a response that requires WASH health coordination. Then the CATI teams will respond by most of the time visiting the case household and completing interventions, and then also visiting the neighbors around the case in a radius to also provide neighbors interventions. They provide these interventions to interrupt transmission, and it's not just about WASH, it's multi-sectoral and WASH and health. We'll say there's no standard current definition of CATI. The implementation varies, the radius, the intervention, the naming varies. Some people may call it a slightly different name, and the timing and the outbreak that it's implemented vary. And so we wanted to briefly summarize pre-existing research on CATIs. And the first set of research is spatial analysis of cholera cases. And these two manuscripts show us that the cholera risk is highest in those living nearest to the cases. And the risk is higher but decreases the further you are away from the case. This research underpins why it's important that targeted interventions like CATI have potential to reduce the caseload. Then there's modeling data. There was one study that used a simulated outbreak with different times in the outbreaks CATI happened, different neighbor radius or rings, different interventions, vaccines, prophylactic antibiotics, point of use water treatment. And this modeling study found that CATIs can shorten outbreaks and that CATIs are more efficient than mass campaigns. Then there's been some implementation studies in Cameroon and DRC to see how it is to implement CATIs. And the results of those were that CATIs should be implemented with WASH and health interventions. And after the implementation, cases decreased. So this is an indication that there might have been some impact. So this implementation research is showing that CATIs can be implemented, but there are challenges, particularly around the timing and the outbreak they are, and the cost and other logistics. Then there's been 3 reviews of information on CATI from country implementations, 1 done by UNICEF and 2 done by sets of researchers. These reviews have pulled together the academic literature and country experience, and they have provided some recommendations on how to implement CATIs. And just to note that any of these manuscripts, you can ask us, we can send these on to you if you're interested. And then lastly, do CATIs actually reduce cholera? There's been 2 studies that look at disease reduction, one in Haiti, one in Bangladesh. In a randomized control trial in a stable hospital setting in Bangladesh, where kits were given to families with training, they did observe a 47% cholera reduction in people around the cases after the distribution of this. There was also a retrospective observational study in Haiti during the outbreak, during the kind of long tail of the outbreak, where they found that CATIs mitigated and shortened outbreaks. So there is some indication that CATIs reduce cholera. The ultimate goal is reducing the transmission of cholera onto subsequent household members or neighbors. But there's an issue of context. A stable setting or a retrospective study may not be the representative of all cholera outbreak contexts. So where we're at now with the open questions in research are around efficacy. Do CATIs reduce cholera in rapid onset outbreaks at different times in the outbreak when they're implemented quickly? And importantly, what's the intervention package that should be delivered? What's the optimized intervention package? And there's research ongoing onto this. And then also, how are these implemented? What's the cost, the staffing, the appropriate ring size? These are intensive interventions, and understanding how they're implemented is a research question that people are looking at. So I'll end with my intro 5 minutes, quick summary of the research, with a quote from Ruwan's paper. Although CATI shows promise for outbreak control, it is critically dependent on early detection capacity, that link between WASH and health, and requires further evaluation to evaluate the effectiveness of different packages of interventions. So today, as part of the Tufts Research to Action project, funded by BHA, which has 4 components, one of which is our research webinar series, I'm thrilled to have 3 speakers who are currently doing CATI research to address these gaps, who are going to share their results or share what they're doing, their methods and results, to fill in some of the evidence gaps with the most recent research. So I will turn this over to Lindsay, Salem, Bango, and if she could please take the screen, and we're happy to take questions in Q&A.
Great, thank you so much, Danielle. Okay. Hi, everyone. My name is Lindsay Salem Bango, and I am a research associate at the Johns Hopkins Center for Humanitarian Health. And I am so excited to speak with you all today about our operational research project on CATIs and cholera outbreak response in humanitarian and fragile contexts. Our study aims to analyze the effectiveness of CATIs in humanitarian and fragile contexts and to document the challenges and lessons learned in implementing CATIs in these settings. We've worked with absolutely incredible partners, especially SI and ACF in Borno, Adamawa, and Yobe in Northeast Nigeria during a cholera outbreak that primarily occurred from September to December of 2021. Our study is a prospective observational study with a quantitative and qualitative arm. The quantitative arm has 2 what we call phases. So phase 1 data collection occurred at the time of CATI implementation, with enumerators being embedded within the CATI teams and documenting the different response efforts. Due to the nature of CATIs I'm seeing we can't see the presentation. Is that, Chika, are you able to see it?
I'm able to see your screen.
Yeah.
Okay. Oh, someone else can see it, so I'll keep going. So just due to the nature of implementing CATIs in an urban setting, we ended up with a lot of overlapping rings in our data. So we've landed on an analytical methodology called SAT-SCAN. And at the most basic level, SAT-SCAN helps us identify the clusters of disease cases over space and time. And so we're able to adjust for CATI and environmental factors and analyze the impact of CATI on the clustering of cholera cases over space and time. For the phase 2 data collection, that occurred 10 to 14 days after the CATIs were implemented, with enumerators returning to the CATI rings, and especially looking for incidents of acute watery diarrhea among household members. And for this phase of the analysis, we are using a multi-level regression to look at the impact of different household and ring level characteristics on the odds of acute watery diarrhea after receiving CATIs. The qualitative data was collected through key informant interviews, or KIIs, with CATI team members and headquarters staff to really allow us to dig deeper into some of the challenges that teams were facing in implementing CATI. So the analysis is still ongoing, but we are able to share some preliminary results on some of the challenges in implementing CATIs in these settings, linking some of the key informant interviews with some of the quantitative data from our phase 1 data collection. First, teams often struggle to reach all of the cases during the outbreak. So as you can see in this chart on the right-hand side, the blue shows the number of cholera cases on the line lists provided to teams from the cholera treatment centers. And the red shows the number of cholera cases that teams were able to respond to that same week. And as you can see, especially during times of high caseload, there's just a limit to how many cases teams can respond to, especially with the staffing they have. Teams were also sometimes unable to reach certain cases due to security concerns, especially in Borno, and inadequate contact information also prevented teams from finding the cases sometimes. Teams also struggled to implement the full intended radius. Both of the organizations we followed used a radius of 150 meters, which is quite large. And in a rural setting where there are not as many households in a ring of that size, it's much more feasible to reach all of those households. But most of our teams were operating in an urban setting with a much higher population density. And at times there were several hundred households within a ring of 150-meter radius. And so that just becomes unfeasible to reach all of those households. And lastly, supply stockouts greatly impacted the quality of the implemented CATIs. As you can see from the subset of data, in Borno, 97% of case households received aqua tabs compared to only 53% of neighbor households. And similarly, 96% of case households received soap compared to only 43% of neighbor households. And so this is, in part due to challenges in supply chain, but also due to just the sheer number of households that teams are trying to reach. You can see here that's over 21,000 households just for neighbors in Borno. So these and other findings have led us to develop some preliminary recommendations. First, teams should strongly consider using more context-specific radii that take into account population density, human resources, and supplies. Successfully implementing a radius of 150 meters just requires a very large amount of staffing and supplies. And the CATI teams in our study really highlighted the impracticality of such a large radius in communities that are very population dense. And so while using that large of a radius might reach additional households that are at increased risk of cholera, having a smaller radius may be a more balanced option, especially for teams operating in resource-constrained settings. Second, there's often going to be discrepancies in SOPs versus what's actually implemented just due to unforeseen events and challenges arising, but having more explicit guidance in SOPs on how teams should approach predictable context-specific challenges would better support more coordinated and measurable interventions. We found that when teams faced different challenges, they sometimes adopted different approaches to those challenges. And this kind of incongruity can hinder both the effectiveness of interventions as well as our ability to measure the impact of certain strategies. Organizations should, of course, also ensure sufficient staffing, training, and transportation throughout all outbreak phases, especially with an eye for surge capacity during times of high caseloads. And this includes having adequate capacity to conduct quality control of response interventions. But of course, this is a lot easier said than done. And then lastly, CATI response would benefit from improvements in surveillance and data management, particularly around line lists, mapping technologies, and coordination among partners. So to conclude and to wrap it back into incorporating research into practice, this was a purely observational study which provided us with a unique opportunity to study the effectiveness of CATIs in an uncontrolled environment. Our qualitative and quantitative data is also highlighting new challenges that are arising in CATI implementation, especially with more outbreaks occurring in areas with high population density. And lastly, our study is revealing some challenges in researching the effectiveness of CATIs and underscoring some newer analytical methodologies to address these challenges. And with that, thank you so much, and I'll pass it off to the next incredible speaker. Thank you.
Thank you, Lindsay. That was great. Next up is Andrea Martinsen, who is a public health engineer at CDC.
Oh, thanks. Sorry, just let me share the slide view. Apologies, I'm not able to share the, let me see. There, can you guys see it? Sorry about that.
Yeah. Yes, that looks great.
All right, thanks so much, and sorry for the delay. Good morning and good afternoon, everyone. My name is Andrea Martinsen from the US CDC, and today I'm going to go over some of our work, our collaboration with UNICEF, with a focus on the work in Eastern DRC. In terms of the evaluation of CATIs, we're looking at this as kind of a two-phased approach. So as the use of CATIs expands to more and more cholera outbreaks, there's a need to both document how they're being rolled out, but then ultimately, as Danielle mentioned, to look at the health impact. So in DRC, first, we wanted to look at the performance of the teams to assess how cases are being responded to, within what time period, and what's the uptake of the WASH package delivered. Then in phase 2, we want to add this additional component of active surveillance in and around CATIs to document cholera cases. For phase 1, we conducted the first performance evaluation in North Kivu in and around Goma in 2021, for which I'll present today some of the key results. And then phase 2, we plan to conduct this in Tanganyika this year with UNICEF, a repeat of the performance evaluation, but the added documentation of cases around CATIs. So before I go into the results of the performance evaluation, I just want to provide some additional context for the implementation in DRC for those that may not already be familiar. UNICEF began implementation in early 2020 in 4 health zones in North Kivu in and around Goma. And these were integrated teams that were both provincial health staff and NGO partners. And in the case of North Kivu, this partner was the DRC Red Cross. For the WASH package that was delivered in DRC, it was a larger cholera kit listed here for the case households, and then a smaller package to the surrounding households within the cordon sanitaire or the radius. CATIs also included household disinfection, hygiene promotion, and in some cases, some community level interventions as well. And since 2020, implementation in DRC has expanded to 2 additional endemic provinces in Eastern DRC. These are South Kivu and Tanganyika. So very briefly, here's an overview of the monitoring data from the partners. As part of the CATI implementation, the teams collect their own internal monitoring data on some key indicators, such as the number of cases responded to, the time between alert and the CATI visit, as well as the number of houses reached and the package delivered. So on the graph on the left, you can see the proportion of suspect cases that received a CATI visit in the 3-month period of this evaluation between February and April of 2021. Approximately 93% of all suspect cases received a CATI. So interesting to compare this with what was presented in the Nigeria context. This was a year into implementation, relatively stable number of cases in North Kivu at the time. So high level of coverage. Then on the right, you can see of the CATIs that were delivered during the evaluation period, we had 71% that received a visit within 24 hours and 95% within 48 hours. And then average number of households reached was about 18.9, and number of persons 144. So just between 7 and 8 per household. And then of the household water treatment products, soap and houses disinfected, these were all around 18. So in general, all households reached within the cordon sanitaire, within the radius. Just to note, the household water treatment products consisted of both aquatabs and liquid chlorine, depending on availability. About 75% of households received aquatabs. Now moving on to the external evaluation that we supported on. So in terms of the questionnaire, we administered a baseline at the time of the CATI response to suspect cases, as well as to a sample of surrounding households within the radius and a sample outside of the radius. Then we visited these same 2 households 2 additional times and administered the same questionnaire, but with a few additional post-intervention monitoring questions about the intervention. On this slide, we're presenting the quantity of 2 different products that were included in the package, soap and aquatabs, from what they reported to receive during the CATI visit, so represented in blue, and then what was observed remaining at the first and second visits in orange and gray. At the first visit, most households had already used most of their soap, and very few households had soap remaining after that 1 to 2 week time period. For aquatabs, there was a sharp decrease in aquatabs between the baseline and the first visit, potentially indicating a large use within the first couple of weeks after the CATI visit. However, we saw a much smaller decrease between the first and second visit. On this slide, I'm presenting both the self-reported household water treatment as well as the free chlorine residual and stored drinking water. So between the baseline and first visit, both of these indicators, we saw an increase in households that reported household water treatment and that had a detectable FCR in their stored drinking water. On the graph, the case households are represented here in blue, and the surrounding households by green, and then the gray line are those households outside of the radius. Also, just to note, while there was still an increase in the detectable FCR, similar to other studies, so not surprising, this was in general lower than self-reported treatment. And then finally, just wanted to note that between the first and second monitoring visits, both these indicators, there was either a decrease or no change between the first and second visits. So this is a bit of a busy slide, but during the performance evaluation, we also asked a number of knowledge questions at all time points. Here in general, on the knowledge of key times to wash hands, there was across the board either high levels of knowledge to begin with on hand washing or an increase in knowledge after the CATI visit. And finally, just to summarize some of the key points, during the evaluation period, as we mentioned, there was a very high coverage of suspect cases that received a CATI visit and a very high number that received a visit within the targeted 48 hours. Secondly, we found that most households had no remaining soap after the first visit. This may be due to households using soap for other purposes besides just hand washing and hygiene, but also suggests that we may want to revisit the package in terms of quantity and the type of products delivered. For household water treatment, we did see an increase between the baseline and first visit. So those first couple of weeks following the CATI visit where perhaps there's a heightened perception of risk. And we saw this across all the indicators showing similar trends. But this drop between the first and second visit suggests that potentially more follow-up, systematic follow-up is required to sustain the more longer-term behavior change. We also saw that knowledge of wash practices increased, such as the example of key times to wash hands. Of course, this doesn't necessarily translate to behavior, but one study that is ongoing in South Kivu around CATIs is looking more at the behavior change around hand washing and doing actual observations and spot checks in addition to knowledge checks. And then finally, in terms of next steps, as I mentioned earlier, we do plan to conduct a phase 2 in DRC this year. That would include a repeat of this performance evaluation, but further study on the geospatial spread of cases. And lastly, as the use continues, it's being used in Malawi and Mozambique currently, as well as other areas where there's ongoing cholera outbreaks. We plan to provide ongoing support to UNICEF to enhance monitoring and documentation of how CATIs are being rolled out and ultimately their effectiveness. So with that, I want to thank all of our collaborators in the field, the UNICEF team, as well as the Red Cross and the evaluation team. And here you can see Tom and I's contact, as well as our other colleagues working on this. Thanks so much.
Okay. Thank you so much for that presentation. For our last presentation, and then we'll go to questions after that, and you can also type questions in the Q&A. I'd like to turn this over to Ruwan from London School of Hygiene and Tropical Medicine.
Hi, everyone. Let me just do the old sharing of my screen. Here we go. Okay, and I hope everyone can see my presentation. Yep. Perfect. Okay, let's get on with it. Thank you so much to the presenters for setting up a really nice discussion here. I'll be presenting on our ongoing business of CATI in Democratic Republic of Congo. And this is on behalf of Epicentre and MSF, who are evaluating and implementing, and the team from LSHTM as well. As a collaboration, we're doing this together. So it's important to zoom out a bit and understand what some of the goals were for MSF to engage in this strategy and to evaluate it. As Danielle has been saying, we wanted to define a strategy for MSF to implement CATI with vaccination in different countries. There's very little evidence on CATI being a new strategy, kind of defining the contours of what it is. And, you know, it seems like if vaccines are scarce, this might be a good strategy to target people most at risk while also doing a multi-component package as we normally do in cholera. We wanted to do a prospective study because retrospective studies obviously have limitations in terms of what you wish you could have collected and done. And really this was to guide future policy internally within MSF and then externally. So this is a little bit about how it's currently implemented sort of ad hoc by MSF. It's a multiplayer intervention, traditionally using within MSF GIS to define this 100 to 500 meter radius around cases. And the reactivity is the primary objective. It's to address a new cholera case within days of case presentation with this ring around the case and doing these interventions. The package now includes single dose oral cholera vaccination, a hygiene kit with point of use water treatment, a container to store water, soap, hand washing station, antibiotic chemoprophylaxis for households that are closest, neighboring households to the primary case household, and good intensive hygiene promotion. This might not be the same for CATI and others in different settings. So for instance, we just published this work from the MSF Cameroon team, which showed OCV CATI following an OCV campaign, where if you see on the epi curve, the campaign is the black arrow, and the CATI follows to kind of squash out sporadic case clusters that have popped up. So we're able to sort of show implementation. It can be done on the heels of an OCV campaign where there's leftover vaccine available. And kind of repeated this exercise in a different context in Cameroon in September as well, without any study or so forth. So let's move on to the actual study. So we designed a prospective observational study where MSF was implementing the intervention, and Epicentre and LSHTM are evaluating how it's implemented and sort of the effectiveness using an prospective observational design. This is originally thought of as a generic protocol that could be applied to DRC, Cameroon, Niger, and Zimbabwe. You can find more information on this paper, but essentially we wanted to sharpen up the exposure, which is CATI, by using the same approach every time with GIS to define a very clear ring approach and make it practical, and then also define the outcome very well by using RDTs to sort of verify some cases. I'm going a little quickly because I want to leave time for questions, but the primary objective of the evaluation is to evaluate the effectiveness of CATI to reduce cholera incidence as a function of the delay in actually getting to those rings and after the case has been identified. And so we use rapid diagnostic tests to improve the case definition, and to improve this exposure ascertainment, we use GIS to define the ring using a common GIS package, which you can see here. The pink triangle is the primary case, sketches out a ring, and then we match that with a green sort of etching out of what a practical area would be to address in this high-risk area, how we can address properly that size of ring. We did a population-based survey about 3 weeks later to look at uptake of these interventions, especially WASH interventions. And we went for a sample size of 100 CATI rings to achieve some power. This is in progress. This is how it worked. And in the DRC, at this moment, MSF has completed in various locations 118 rings, which is the areas where CATI is targeted across different sections of MSF. And you can see here where that's happened. So just to give you a little flavor, just a little preliminary data, and give you a feel for the operational aspects of CATI and what might be working and what's not working in some ways. So this is preliminary data on 87 of 118 rings. So just focus on the red box there, rectangle. So what we're seeing in general is the number of households and people per ring are generally manageable. It's under 400 on average people per ring, and under 100 households. And the administrative coverage, at least, of vaccination is pretty good for first dose vaccination at ranging from about 70 to 90%. The delay is really important to us. So the delay between the onset of symptoms of the case and even the notification of the case to the start of CATI. And what we're seeing is, on average, it's around, under 3 days, 2.5 days. CATI lasts for about 9 days. And it's because it's been in these dense urban settings in a lot of cases. And we're seeing similar findings for, the vaccination campaign component part of CATI. And so this slide will also give us a little bit of an idea of where we're going with the effectiveness results. So as I said, we are concerned about how many secondary cases can be tracked when doing active surveillance in that ring after CATI's been implemented for about 30 days after implementation. And actually, if you go horizontally, you'll see the number of positive cases being enriched RDT positive cases. They really ranged from about 0 to 7 cases after implementation within those 30 days. So very few cases detected through active surveillance in the 30 days following. And just because it's a WASH audience and you all love coverage, I know that. This is just a little snapshot of something we were addressing in these types of studies early on, where we had a number of rings where through the coverage survey, we found that OCV coverage was good, vaccination coverage was good, and households reported to receive the hygiene kits and those components about 3 weeks later when we checked. But we could only find about 30% of the households that had water containers still, and even fewer who had hand washing stations. Aqua tabs were available in 90% of the households, but only 14% had safe free residual chlorine levels in their drinking water. But still, OCV coverage was high. This is a problem, and I'm sure you can tell us why. So just to zoom out again, this is the current status of the study. We're hoping to proceed on with the effectiveness analysis in 2023, and we've achieved what we need for adequate power. And in terms of broad first conclusions, we can see implementation-wise that rapid implementation is possible following primary case presentation. This is, of course, with combination Ministry of Health and MSF teams who are very capacitated to do this and pre-positioned in some ways with supplies, vaccines, and so forth. Coverage of the first dose of vaccination is pretty high. Uptake of WASH interventions is lower than expected when we check later on. And I'm reminded from Andrea's excellent presentation that we don't know what happened in those first days right after CATI was done. Maybe Aquatab use was much higher then. Few secondary cases is a bit promising for us for effectiveness in general. And so Danielle had encouraged us to think about what we can do now. So essentially, I'm really speaking to the results of our study rather than implementation, but we're really looking to establish CATI and the how and the when of how to establish CATI as a strategy that could be folded into preparedness and response plans for cholera, starting with DRC, harnessing some of the findings of this study and others. One essential question for us is, MSF bought a small stockpile of Uvacol vaccine, but is it possible to establish a permanent small vaccine stockpile for CATI in country? That goes hand in hand with strategy and planning within the national plan. The choice of interventions is an open question. We still, as an open question, we want to understand which interventions of the package contribute to the effect of, if there is one, and to what extent. And we would love to do, within this context and then others, a deeper dive into what drives uptake of the different WASH interventions, household WASH interventions. So I'll leave it there for Q&A, but thank you to everyone involved, especially Dr. Nana and Innocent in Congo and the Ministry of Health there. Thank you very much.
Thank you, Ruwan. That was great. So now we're going to turn over to Q&A. We've had a lot of questions already in the Q&A box. Maybe I'll just start off by looking at some of the open questions. Okay. So the first question here is, do we have any idea how long mild cholera cases can really transmit cholera, and thus for how long the NFI items should last in the family? Ruwan, do you want to take that question?
Yes, I do. I'm just trying, if someone else can start, that'd be great. I'm just trying to stop sharing my screen. My apologies.
Sorry about that.
I think the time that someone can be shedding and transmitting cholera varies, but there is a sense that providing interventions for 30 days, because someone might shed for kind of in the range of 7 to 21 days would be the right amount. Ruwan, is that what you were thinking?
Yes, and I think operationally speaking, we have this idea of what the spatiotemporal window of risk is, which is the radius that we keep talking about, but also the time, which is around 5 days for the highest risk. So if you're thinking, how long should we take to complete this ring? After 5 days, some of the evidence shows it might be less effective, still effective, but yeah.
So important to both get to the household quickly within that
Yes.
5-day window, and then probably provide interventions for in the couple weeks to a month window.
Absolutely.
Ruwan, I'm actually going to take advantage of being the moderator. I wanted to ask, why did the CATI take nine days?
Yes, so that's a great question. I mean, I think it and some of the other presenters have talked about this as well. In some of the areas we're addressing, it's both rural and where there's, it's easy to define a ring or what have you. But then some of the contexts are in Goma, for instance, in Congo, which is a dense city like any other city. And so, it's an interplay between reaching those households in that radius within the allotted time that you have and the time of high risk. And I think that had pushed up the time it takes to reach all of those households in that specific context. But I think on average it was less than that.
Okay. Yeah, thank you. So that's interesting because that's like your choice of the neighborhood then might also affect the timeliness of the response. Okay.
Yeah, exactly, and I think the teams really you have to make a judgment call as well. Is it going to be realistic to cover this pretty giant, densely packed risk area in a big city in the time you have, or are you just going to be? Is it going to take you 15 days to do it?
To come
Thank
back
you.
come back to some of the questions. One of the questions asked if there was any negative impacts of CATIs. And there's been a number of questions that have looked at, like, are they taking resources from other teams like polio? Are there negative impacts in the community? Can anyone speak to that? Anybody?
I guess it's just or I can go for it. We in less so in terms of negative impacts, but we did see that there are some instances of households, not wanting CATI interventions for a variety of reasons, but in part due to either not trusting CATI teams or being concerned about people associating them with a cholera case. There was a great question about staffing and perhaps taking staffing away from health facilities. I think that highlights the importance of coordination with all of the different partners in an area. So for our study, the implementing partners were NGOs working in the area. And so it wasn't the health facilities implementing CATI, it was a partnering organization that was able to bring in additional staffing and volunteers to take on that burden of response that it wasn't on the health facility itself. And so I think that kind of coordination also helps with alleviating additional burdens from health facilities and taking people away from other programs.
And just to add to Lindsay's answer as well, in this context, the operations for CATI for MSF involved, yes, it involved MSF teams and also Ministry of Health teams. So it did take a little bit away. It also concentrated the response in certain areas in a sort of a shortened time. There's also a reliance and dependence on community health workers as well, or community health volunteers, I should say, in this particular context to do surveillance and so forth. So that has to be also made palatable for communities and for those community health workers to be able to contribute to doing the surveillance for early detection of cases and all the in some instances we've seen delivering some of the interventions as well. And that was definitely a feature of doing CATI in Cameroon.
One of the questions was from Jessica. It would be interesting to see how many secondary cases there are on average without CATI intervention to really appraise the impact. And I know a number of these studies do have health outcomes as an endpoint. The data is not quite there yet, but it'll be forthcoming this year. Will there be a comparison, a control in any of these studies between people with CATI interventions in a ring and people without?
I can start that. I mean, one thing that we're thinking about looking at, rather than looking at those that received a CATI and those that didn't, potentially looking at the timing of CATI. So those that received within the targeted 24 to 48 hour window, and those that had a delayed response, and comparing those.
Yes, similar to add on to that, one of the challenges, because I completely agree, would be we'd love to look at the looking at cholera among cases who did not receive CATIs. A challenge there is with location data. So if with the line lists, it's often very general location information, and without knowing explicitly where that case is, it can be hard to follow up and actually look at the incidence of cholera in areas that did not receive CATIs, because we don't have their exact locations to pinpoint a more exact, did this smaller community not receive as many CATIs? So that's just a challenge in trying to answer that question that I think we would all love to have a better answer to.
Just a quick note, we do have some of that data in general, cholera surveillance data, and where CATI hasn't been applied in similar areas to where it had been applied. So it's still, in the back of our heads, how do we use that as a comparison? But in general, the original protocol was, relies on the fact that CATI takes time to implement, so we have various delays to getting to those rings, and so we can use those rings, those delays, to say to assume that a faster implementation or lower delay could be more effective than a longer delay. So that's something we're juggling with now.
Fantastic. There's a couple questions that have been upvoted that are around how to make staffing more efficient, how to respond more rapidly in a staffing team configuration, joining about the recommendations you can provide on the best team to respond quickly to be more effective. What are the ways to get the people to the household faster?
That's a very good question that I don't know if I have the answer to, but perhaps maybe just a little bit of context, like what's going on in Mozambique right now. It's being rolled out slightly different from between different areas. Some are much more dependent on NGOs and larger teams, whereas other ones are more local with community health workers. So in terms of kind of what's needed to roll out the large teams with NGOs versus the small teams with community health workers, it may be a lot faster to move the more localized teams. But I'm not sure if I have a good answer for that, but just some additional context in how it's being done differently in Mozambique right now.
We've done some evaluations of not CATI, but CATI interventions, and something we've seen. These are very implementation-based things, but it can be difficult to find the house. And so giving the CATI teams minutes on cell phones so that they can call people, getting them a cell phone number, giving them cars or motos so they can get to the house, traveling with a family member so the family member gets them there directly. These are very like implementation based recommendations, but it's helped with the timing of getting teams there faster when they have the resources and they're not driving around in circles or walking around in circles asking, I'm looking for this house. There's a question about that I think is important to address about the global shortage of OCV. Right now, we have the largest number of cholera outbreaks we've seen in a long time, and we have less OCV than we've seen in a long time. How can we manage? How do we move forward with that? How do we target the OCV we have?
I think that's a golden question. That's super difficult to answer, as you can imagine, James. I think in general, if we think about the context about how CATI's been delivered historically, in near history at least, it's been a lot of CATI on the heels of an OCV campaign as a tool for that campaign. So once the epidemic is receding a bit and the campaign is done, we have some leftover vaccine. How do we use that well? But I think there is no policy for procuring vaccine for a given country, specifically for CATI. So this could be an option for actually saying, well, what would a small OCV stockpile look like for the purposes of CATI that could be redistributed in country to address, again, a very context-specific application, which could be, for instance, addressing a new outcropping of cholera in a remote part of a country that would be very difficult to address with a mass campaign once the epidemic proceeds on and gets much bigger. So really prioritizing where small outlays of vaccine for CATI could be used in a small stockpile and going back and making that into a policy for procurement in a way.
There's a couple questions. We saw really different uptake of the WASH interventions. Often in CATIs, you might have chlorine tablets or soap or disinfection items or any WASH intervention at the household. And there's been really different uptake levels across interventions of those WASH, some quite low, some higher. And there's some questions about, can CATI be linked in with behavior change, or how can these be increased, or is there ways to give items that might be that might be from the point of the view of the population a little bit better? So there's a couple questions circling around that. Anybody have anything to add on that?
I'm definitely the least qualified to talk about WASH. Oh, there's Tom. Tom, please go ahead.
Yeah, I'm going to take advantage of the pause. I think a lot of the questions can be addressed if we have some kind of preparedness activities beforehand. So rather than waiting till a new outbreak occurs and then mobilizing a team and then coming up with a package and then how to deliver the package, in areas which have repeated outbreaks or at high risk, starting to mobilize beforehand, maybe doing some qualitative work about what would be an appropriate package, what would be the delivery mechanism, should we use local NGO staff versus Ministry of Health staff, et cetera. Some of that stuff can be done beforehand. It's not going to be ideal because we don't know where the outbreaks are going to occur, but within areas that have repeated outbreaks, kind of thinking through and mobilizing the resources, I think could help alleviate the difficulties in mobilizing and some of the uptake of those interventions. And that's kind of what Christine Marie George is doing in South Kivu right now, kind of looking at the qualitative uptake. What are the barriers so doing that in advance, I think, could help with the uptake. Thanks.
Yeah. And just to add to that, one of the things we see consistently is populations will use in emergencies and humanitarian response what they knew from before the emergency. So it comes back to your preparedness. If they've never seen a chlorine tablet and get one in a CATI kit, that's not something that might be highly used. But if there's information beforehand and knowledge, it changes. And you also bring a really good point. You mentioned government, and some of the questions have mentioned working with government. We've presented here a disproportionate amount of NGO response in CATI, but can anyone talk about working with governments?
I can just speak briefly about what's being done in Malawi right now. It's actually, they did a TOT in November with UNICEF support, and then now it's being rolled out all entirely through the Ministry of Health at the district level. I will say that with that, I think that there's been some significant challenges in the logistics and the consistency of the rollout from district to district. So not having that logistical support with NGOs, I think, has been somewhat of a challenge in working directly with the district health offices.
I can just give a quick thought. We were trying to work with the Ministry of Health in Cameroon to kind of formalize their CATI approach as well. So that is a nice area where we're seeing all of the ideas about how to transfer such an intervention with vaccination over to kind of a general strategy that could be rolled out by Ministry of Health. So that it just requires a lot of coordination, but with them calling the shots of where it's going to be implemented, there's certainly a lot of promise.
Yeah, and certainly in Haiti and Yemen, which we haven't talked about here, there was strong collaboration with government agencies as well. In the Haiti, a very long-term CATI response, as well as in Yemen, and so a longer-term response may involve more government. I'm conscious it's almost time. There's two questions about kind of more challenging contexts. If there's any information about cholera cases in response or CATI in Afghanistan, and then cross-border, this kind of the borders of DRC, Zambia, Malawi, Mozambique, where there's a lot of cholera right now, but these CATI responses may be within one country or one state. And so how do we manage these more challenging responses with CATI? Or is that future research?
I'll take a stab at it, sorry. I think the use of CATI cross-border is actually an excellent use of the teams. So there was cases that were introduced into Burkina Faso, I think it was 2 years ago, and they're squashed out very quickly. It wasn't officially a CATI team, but it was a rapid response team that found the cases and did the proper interventions and basically reduced it to a cluster of cases. And I think cross-border, to reduce the wider spread transmission, to get those quickly is an ideal use of CATIs. Early on in the outbreak, new introductions, how to squash it out quickly, or towards the end of an outbreak, that's the best use of the CATIs, I think. There was an earlier question I just saw in the chat about when do we switch to larger scale interventions? And I think that's the great question that really needs to be determined. When do we use CATI and when do we not use CATI? When do we do larger types of interventions around cases? And that's something that really needs to be addressed. Thanks.
Yeah, coming back to when is it targeted or when does it go back to blanket because there's enough cases, right? And that comes back to Haiti, where they defined a certain number of cases per community that had to happen before there was a CATI that included community interventions. Or do you just go back to blanket distribution? I think,
or something in between. So not a huge community, but something larger. It's kind of what UNICEF's calling a cluster, but something that because it's an environmental source that's contaminated. It's not just person to person. So if we know those sources are contaminated, let's address those drinking water sources.
okay, we are at 1 minute past, but I'm also thinking we're almost cleared out the chat or the questions. So how about Jenny's very important question of feeding the the findings back to the communities. Are researchers doing that? How is that going? What were their responses?
Yes, we've been in our study, feeding back our preliminary findings to SI and ACF, and at least with SI in particular, they've been starting to revise their CATI SOPs for ongoing and future cholera outbreaks based on some of these preliminary findings. So we're able to, again, feed the research immediately back into current practice and SOPs for CATI response.
And that's to the NGOs, but to the community members themselves.
Yeah, that's been specifically for the NGOs.
Yeah, and I think in DRC, they've been very good in having regular research meetings with government and NGO partners led by UNICEF, the CAI, the Integrated Analytic Unit, I think it's called. So that's one way to feed back the results to the partners. I think perhaps missing the feedback to the communities, but at least they're working hard in DRC and getting back to the partners. So.
And I think on our end, there's been a fair amount of, hanging out in the communities. The teams are there, so there's a lot of discussion with the communities, and typically there's an entry point with the community leaders, even in urban settings. So there's a lot of discussion about what's being done, what the anticipated outcome will be of this implementation of CATI and so forth. And that's essential for doing the surveillance in the ring and working with the community health workers. So in terms of the formal discussion of the findings later, I mean, that's definitely part of it. These are community interventions. So I think that's going to be important, especially as I think Andrea and Tom were saying, you want to do this again and again in places where there is cholera. Well, it's a community intervention. We have to tell people about how it's going.
And then I'd just like to thank Stuart for mentioning the Global Task Force on Cholera Control and the National Cholera Control Plans, the implementation strategy with the government as those national cholera control plans get up and running in countries as part of that process. And I think that's a really important structural thing to mention. And so thank you for that. And the chat answers are cleared. I just wanted to say thank you to all our presenters. I'm going to hand it back over to Yika to end us today, but thank you for everyone, and yeah, I'll back to Yika.
Fantastic. Thank you, Danielle. Well, thank you all for coming. Thank you to all presenters. Those are wonderful presentations and lots of really great questions, and thank you for answering those. We will be sending out a follow-up email, hopefully with the link to the webinar with captions, and we will also be sending out a short survey to help us figure out how we can do these webinars better. So please fill out the short survey that's going to come with a follow-up email. We would really appreciate it. And everybody have a great day. Thank you. Bye.
Thanks very much.
Thank you.
Thank you.